section. So without further ado, I'm going to stop sharing and hand over to Ben, because he certainly needs enough time to tell us some of his wonderful magical stories. I will mention that Ben has recently written a book, which I hope he'll tell us about, which I've just finished and found a wonderful journey of his journey from starting as a clinical manager at Zithulele Hospital. That's more than 10 years ago now, and extraordinarily to see what it is to take a very under-resourced, very rural hospital and how to really transform that into one of our benchmarking rural district hospitals, certainly in the country. And Ben has gained a lot of experience through some proper trials and tribulations of what it takes to really do the work, and then also to see that it's possible, that with very little you can achieve extraordinary things. And so he really knows the ins and outs. He's working in the OR Tambo district, probably one of our poorest districts within the Eastern Cape, which is one of the poorest provinces in the country. And he's managed to create an extraordinary health service delivery, even in those circumstances. So we're really looking forward to what he's going to share with us this evening. So I'm going to hand over to you, Ben. Do you want to start sharing your screen?
Yeah, let's do that. Thanks, Madeleine. I hope everyone can hear me clearly enough. And thanks for the introduction. I think, as with most introductions, it's probably slightly too generous. But yeah, I do hope that the Zithulele story can at least show what is possible in our province. It's a province that's often written off in the news, but there's tremendous opportunity here. And yeah, we've had a fun journey coming up, 16 years, and many more to come, hopefully. We certainly haven't got the perfect hospital, solved all the problems that arise in the Eastern Cape, but yeah, we do hope that what we represent in terms of what's possible will be encouraging to you. And we also realized, perhaps just to say at the start, that, you know, people, our province is diverse in so many different ways, but in its hospitals as well. So you might be sitting in a small hospital, which has relatively little compared to what we have now. I sympathize and understand that. And so I think it's important to remember that we're all on a journey of trying to provide better healthcare to our people. And so wherever you are on that journey, the idea is that we want to knit in with you, and so especially if you're semi-alone, from a clinical team point of view, that you won't feel completely alone. And I think importantly also, the purpose of tonight and my talk in particular isn't to tell you every last detail. In fact, orientation in general can't be to tell you every last detail about anything. The idea of making the resources available is to, one, put them in kind of a central place so that you know where to look when you're not sure what to do next. But importantly, that you know who to ask. The network of people here, Madeleine's introduced some of the DCST from Amatole, particularly proactive DCST with some wonderful clinicians leading it. But there are a bunch of other people around the province who've made themselves available as resources, and connecting in with those people is often, 9/10 of solving the problem. Knowing who to ask and knowing what's out there is a huge part of it. So perhaps without further ado, to jump into how the ECDOH works. I mean, the cynic would maybe say, and sometimes doesn't, or how it's meant to work. But the reality, is that our province functions a whole lot better than people give it credit for, and also that we're on an upward trajectory. One of our core values at Zithulele is a hopeful attitude. And I think if you're going to work in the Eastern Cape, you have to have a hopeful attitude. It's not perfect. There's plenty of problems. There are plenty of times when you feel like your head is really now just too sore. We've hit it against the wall too many times. But the honest truth is we're on the up. Okay, the health system can't possibly be collapsing for continuously for 20 years, or otherwise it's in a very slow state of collapse. But we can create pockets of excellence, and in fact we can create excellence across the system. So in some ways that's my hope and my challenge in summary. But today we're going to focus on just kind of how it's put together, because nobody teaches you that at med school. Nobody tells you really about how the health system is structured and how it's meant to function. And as a result, we kind of come into clinical practice often quite naive about what should happen, naive about how complex it is, and so it breeds a frustration that could be lessened by a better understanding. And then also, of course, once you understand, you start to know at which pieces you can address things. So I'm a lover of history. And I would, so this slide has got a bunch of ideas behind sharing it as our upfront slide. I think the first thing to say is to remember the historical context that we're working with, and I'm going to get to that on another slide as well. But I would encourage you, if you're new in a place, to find out what some of that history is. This is how our hospital started in 1956. Barely a structure to be seen. I've got other photos of the hills taken by the missionaries back in the day. You know, when there were very few people living actually right here. One wonders actually why the hospital was put here in the first place. But understanding, how did your hospital come into being? What's the history that's happened? How does your community see the hospital? Who are key people in your community in relation to the hospital? You know, for us, meeting the Mfundisi, who has been here since 1990, who in fact retires this month at the age of 65, was key in terms of grounding us in the community. It's very easy sometimes when you go to a rural hospital to live behind a fence and not interact in the same way as you might have expected yourself to. So understanding history is key. We've been able to build on the ethos of caring for other people, and that's been hugely important. But another aspect of it is also understanding what people have gone through and kind of what the local politics might be all about. So I'm not going to give you a history lesson, but also to remember that most hospitals, in fact most rural hospitals in the country, started out as mission hospitals, and that has obviously got pros and cons. Let's quickly pass by some numbers. One of my other great loves, mathematics and stats. So Eastern Cape's huge, eh? We stretch from just about Plettenberg Bay up to Port Edward and all the way inland to Aliwal North. So it's a massive province, the second largest. Only the Northern Cape is larger and nobody lives there. So we've got a challenge on our hand when it comes to providing healthcare. Apologies if there's anyone from the Northern Cape dialed in. There are people there. They're just far apart. And we've got 7 million people to look after. There are 92 hospitals, 28 community health centers, and 711 clinics. It gives you some idea of the scale of what we're dealing with. And certainly gives me a lot of sympathy for the people who work at head office trying to coordinate it all. So this is one of the most important slides, you know, how that coordination happens and how the Department of Health is structured. Remember that provinces are also mirrored nationally. So there's a series of mirrors almost as the system and its different pieces get put together. You will know, I hope, that national government is run by cabinet, who report to the president, and the cabinet has a minister for each portfolio. So the Minister of Health is technically in charge of providing healthcare to the country and signs an agreement with the president. Under the Minister of Health is a Director General and then Deputy Directors General, and then a bunch of different departments that look after the variety of healthcare programs that run in our country. The same is true at provincial level. So there is an MEC for Health, a member of the Executive Council, who's a political appointee, appointed by the Premier of the province, and who is responsible politically for the provision of healthcare services within each province. and then the civil servant, who is the employed head of department, is the superintendent general. Now, in our province, we currently have an acting superintendent general, Dr. Zungu, who is responsible from a service delivery point of view for the health system. So that person is usually employed on a 3 to 5 year contract. We won't get into debates as much as possible here, but you can imagine how a 3-year contract isn't conducive to trying to set direction and policy for a whole department, especially one as large as this. But they are obviously working closely with the political head, but their job is actually a civil servant job like yours and mine, coordinating health and working again with deputy directors general, who oversee things like finance. I mean, being an accountant, they like to call them chief financial officers, but they work at the same level. There's a deputy director general for HR, and one for clinical services, and one for hospital management services. And I sometimes start to get lost at that point, and I think many people do. But to realize that the civil service is set up with levels, this is a crucial concept. Once upon a time, when we first came to Zithulele, one or two nervous types told me, "No, Dr. Gaunt, you mustn't complain so much, and you mustn't phone Mtata and Bishu and tell them about our problems," as if we needed to hide away. And my worldview is different in that respect. As a civil servant, I am employed to do a job. And that job, in my case, is the job of a doctor and the clinical manager coordinating clinical services. And so if I can't do my job, actually what the Public Service Act requires of me is to escalate the problem to the person who I report to, which is the CEO. And if the CEO can't help me, they are meant to escalate it to the next level. But if they're not going to escalate it, then I will. And each level of government is designed like that. It helps with accountability and it helps with service delivery. So understanding that we're all accountable, from the lowest level, the lowest paid employee, to the president himself, we are connected in a chain of command that has its primary, in fact, its almost sole purpose to serve the public. And so understanding those different levels is important, because it's not appropriate when we have a problem in OPD to phone the SG or the MEC. That just usually creates a lot of political heat and noise and doesn't necessarily solve the problem. However, it may be appropriate to escalate it to wherever, the CEO, the district manager, etc. So understanding that is really important. Bishu has got a large number of people in a semi-ugly building trying to coordinate a huge amount of what happens in the province. But there are a lot of good people there, and there are a lot of good people all spread throughout the system. The key is to understand how they fit together and to learn who they are. Now, obviously, if you're a ComServe doctor in a place and you maybe only planning to stay there for 1 year, that's okay. You don't need to know who the whole food chain is, but knowing that it exists and roughly how it fits together can help you understand how to address some of the key frustrations that are maybe holding you back. At district level, and there are, I think, 8 districts, there is another mirror. So there's a district manager who coordinates and is responsible for everything that happens in the district. They in turn have a variety of people who report to them, managing different pieces of the program. Unfortunately, at this point, it sometimes gets a little bit siloed. So you've got, while obviously HR and procurement and various other functions like that need to be separate, once you start separating clinical programs, you do start to run into trouble. So it can be very confusing once you get a HAST manager and then somebody else who wants to know TB, and then the data manager, and then everyone feels like they're asking you the same questions. Don't stress too much about that, but understand that those pressures do sometimes come to bear, especially on nursing staff, and especially if they've been designated as the quality assurance officer or the TB point manager, etc. So we're going to talk about those functions again in a little while, but to understand again that almost everything that needs to happen has to go through at least one, if not two or three of these layers. That's why getting appointments can take so long and be so challenging. The biggest challenge, in my point of view, in the health system as we currently have it, is the divorce at the, not the lowest, I don't like to think of this as a strict hierarchy, but at the level of what happens at where the patients engage. So unfortunately, back in 1994, when we were trying to create a functional health system out of 30-something fragmented departments of health that represented everything from so-called homelands to wannabe homelands to provinces and other completely dysfunctional setups. A big concern at the time was that if there was too much concentrated in the hands of the hospital, the health system would become hospital-centric. And obviously, that is an inappropriate model for our country. And so unfortunately, the solution at the time was thought to be to divorce hospitals and clinics. And so we have clinics in sub-districts, LSAs in brackets, you often hear them still called that, local service authority, but they report separately to a sub-district manager who reports to the district manager. Now, in the Eastern Cape, there's been talk for years about doing away with sub-district managers. That has never come to pass, but many of them are acting as a result of that. You will find actually in government, and unfortunately in the Eastern Cape Department of Health a lot at the moment, we are a kind of quasi wannabe theatre company with a lot of actors, but we are hoping to move more back into health in the new financial year. Anyway, the sub-district kind of runs its own ship sometimes, and the hospital runs its own ship, whereas actually our patients transition, well, they should, seamlessly between the two. So you've got clinics, which are 8-hour primary healthcare facilities, CHCs, which are community healthcare centers, which are meant to be 24 hours and often do deliveries, although there's some debate as to whether that's appropriate in some places, because there is thinking that you should be doing at least 500 deliveries a year to maintain a sufficient skill level. And then hospitals or district hospitals, because of course the other tiers of hospital are regional and tertiary. So that's kind of how they fit together. In terms of who's in charge at hospital level, it's a CEO, also called a hospital manager sometimes. At clinic level, it's usually an operational manager, sometimes another title. And then there's clinic supervisors and all sorts of other job titles that get involved. I hope that's giving you some idea. I don't want to get lost there because it gets a bit tiring. It's important also to understand, this is the boring bit, but it's super important. How do budgets work? So there's two aspects to the main budget that comes into a province, and that is the equitable share, which you may have heard of, and the conditional grant. So equitable share is when Treasury takes all the money in the country and says, okay, we've got X amount of billion, let's pretend nobody's stealing any of it, and let's share it out between the provinces. Now, how should we do that? Okay, let's do it based on population and kind of need, and there's some complex formulas, but basically it gets given to provinces, and then provinces take it and they are allowed to distribute it and use it as they see fit within certain constraints. So in the Eastern Cape, the provincial parliament sits and says, okay, we're going to give this amount to health and this amount to education and this amount to arts and sport and all the other departments, transport and roads and public works, etc. And that's more or less how the health budget gets divided. Now, we're going to come to where the problem lies with that in a moment. But there is another type of budget, and that's the conditional grants. Those are ring-fenced monies that come and that can only be spent on X, Y, or Z. HIV is the main example of that. COVID money is another example. And there are various other smaller programs that have specific money. Also, it's useful to know that the central hospitals, the 10 central hospitals in the country, actually have a completely separate budgeting mechanism as well. Theirs doesn't come from the province. So the idea is to try and give some autonomy to provinces while also making sure that key programs get funded. But you can see the challenges when there's huge need. And in a province like ours, education, for example, and health are obviously the two biggest drivers of expenditure, and there's need. It's hard to say, is it more important to have a clinic well stocked, or to have a primary school built in this particular rural area? And in the rural provinces, especially where we're still dealing with historical inequities, those can be challenging questions. I'm going to come back to that in a moment, but at hospital level or facility level, because the same is true of CHCs, etc., there are three main items on the budget. So COE, I put the abbreviation there because the people refer to it. It's cost of employees, basically. So it's the amount of money we spend on people, and it's the big portion of the budget, 60% plus, sometimes more. As a result, goods and services get squeezed because there's only X amount in the equitable share allocated to us, and there are a lot of demands on it. So goods and services might be a relatively small percentage of the budget, but that's where all the stuff like syringes and medicine and blood supply and lab come from. Even within goods and services, there's five main things we spend money on. It's lab, blood, oxygen, medicine, and a fifth one which escapes me right at the moment. But it's important there to just highlight things like blood accountability and lab accountability. They sound almost esoteric when you feel like you're only just surviving an OPD, but the responsible use of scarce resources is actually all of our responsibility, because at the end of the day, the money pot isn't endless. And so it's quite interesting when you take that step back and you think, okay, gosh, we're working within a system that's constrained. How can I be as responsible as possible? And that's quite an important perspective, because it's very easy to sit there and just have the patient in front of you and think, well, I need to do all these tests, like tick, 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 or let's order 3 units of blood. And those add up once 92 hospitals and all their staff take that approach. So there's a certain amount of responsibility that each one of us carry on the ground for trying to get budgets to work. One of the challenges is that capital expenditure is often separated out of hospital budgets, and that budget might be held by district or even by province. Capital items are frightfully expensive. Theatre tables, for example, cost R500,000. X-ray machines, we replaced ours last year. Well, when I say we replaced ours, province kindly replaced our X-ray machine because the other one broke. But it cost $5 million. It's not small change. And so capital things can be very difficult to get hold of. One of the other problems, however, is that anything more than 5,000 Rand is just about considered capital. So that line item in the budget hasn't changed in amount. It's a treasury line item from National Treasury, so it's very difficult to change. I even tried once. But 5,000 Rand 15 years ago didn't buy you a lot. 5,000 Rand now, hardly buys you a haircut. So it can be challenging getting capital items procured. I'm not going to dwell on it. There's so much more to say. I wanted to highlight this because I think this is really important as well when you find yourself frustrated in the rural Eastern Cape. I spoke about that equitable share. And sometimes I wonder if we shouldn't just call it the inequitable share, because the problem is these guys are running the three-legged race. Okay, you can't run as fast when you've tied your legs together as you can if you just Usain Bolt. And what happens is that, let's say we said, okay, we're going to be equal. Everyone's going to get 100 million Rand to spend. The Western Cape, the Eastern Cape, everyone. Okay. The Western Cape has had years of privilege and has got its posts filled. It's got quality, well-experienced managers who've been there for a long time. And so when they get given 100 million, they spend 100 million pretty well. And they spend all of it. They can tell you what they spent it on. I might be exaggerating slightly, but for purposes, I hope you're following me. And so at the end of the year, the auditor comes and they say, oh, wow, you spent that 100 million so well. The Eastern Cape, we got the 100 million. We don't have as much capacity. We've got some posts which are empty. We've got acting people in posts. We've got people who don't have as much experience as some of those more experienced managers elsewhere in the country. And so the reality is that we only spent 90 million. And worse, we can't actually tell you what 5 of that million went on because we don't have the good records to hand. So as far as the audit is concerned, we spent 85 million rand and stole 5 million, which may not be the case. But when it comes to next year and Treasury handing out the money, they look and they say, the Western Cape says, we'd like 110 million, please, because we've got all this need in our province. And look, we spent 100 million and didn't quite cover it. Okay, so they give the Western Cape 110 million, and the Eastern Cape, we say, well, we've actually got the same amount of need. In fact, more. We also need 110 million. And Treasury says, well, you only spent 85. Well, we'll give you some credit, 90 million last year. Tell you what, see if you can spend 95 million this year. Okay, and when that happens for 25 years in a row, you basically have the rich getting richer and the poor getting poorer. I'd highly recommend going to have a look at this article. This is where we are. And ironically, this is where we are in our own province as well. So the urban areas in our province do better at spending money than the rural areas of our province. And so we end up perpetuating inequality sometimes. It's useful to think about that when you're feeling just utterly frustrated, because we are trying to undo literally decades of neglect and decades of infrastructure and human resource capacity issues that are seldom the fault of the people on the ground trying to make it better now. Okay, right, enough preaching. Right, this slide is completely old and out of date, but for political reasons, the Health Systems Trust doesn't produce it anymore. But nonetheless, I found it another way of kind of realizing some of the challenges that we face in our province. So this is the performance of districts in 2013-14, measured against a whole lot of variables and then ranked by the best district to the worst district. And the Eastern Cape's in yellow. So you can see we are towards the bottom. And that's also helpful when you're feeling frustrated. So, you can, if you came to the Eastern Cape thinking that it was going to be the cushy job, easiest life, then this orientation will be unsettling you. However, if you came to the Eastern Cape thinking that you'd like to make a difference in people's lives, then hopefully you're starting to see that there's a lot of scope for that. All right. What is the Eastern Cape? Yeah, I told you there are 92 hospitals. This is them spread out over, this is a slightly old picture that I got off a wall somewhere. And in fact, there've even been hospitals constructed since it was made. But you get the idea. We've got a lot of people spread out over a really big province that takes a long time to drive from one end to the other, which has its own problems. Hey, if you want to have a meeting in person before Zoom and COVID, where do you have it? I wanted to highlight this briefly as well, just a sense of who's who in your own place of work. Now, I've used the district hospital as an example, but obviously if you're a CHC, you won't have necessarily all of these functions, but many of them will actually exist at sub-district or district level and be of relevance to you. I've also put there that it's a fragile ecosystem. It's a way I describe rural health in general and district hospitals particularly. It's very easy for things to go wrong quickly because one or two people leave. Now, I'm not going to read this slide to you, but it's important to remember that we kind of have mostly three legs of the pot here. We've got clinical services, nursing services, and admin and operations, and then a few things that are meant to be so-called transversal and actually report directly to the CEO. Nursing is structured with a nursing service manager, area managers, and operational managers. That's lingo worth getting used to and working out who's actually who, so that you can again address issues and escalate or make plans with the appropriate person. And then admin usually is overseen by either, they might call themselves an admin manager or middle manager administration or an administrator, and often is split into operations and administration. So kind of the things that keep the structure or the mechanism of the hospital going, and then the stuff that's a bit more behind the scenes and paper based. That's good to know. Like I said, I'm not going to read it to you, but find out who's who. The version of this that I show my team at Zithulele has people's names there because Just for, oh, so-and-so. And then when you meet so-and-so, it's like, oh, that's who they are. Okay, so it's quite useful for somebody to populate that in your hospital. This slide has got three purposes. One, to share that phrase with you, hospital-based but community-focused. I think that is an important way of going about rural health. We don't want to be hospital-centric, but hospitals do have a certain amount of momentum, both clinically and socially, and an ability to attract and retain staff that clinics, especially in small places, really lack. But we have to be community-focused. You will find that if you work in a rural hospital for any length of time, you will discover how real the challenges are just 5 kilometers from your door, let alone 50 kilometers from your door. And so if you're expecting everyone to come to you at the right time, you're going to be bitterly disappointed. So getting out to them and having structuring your services in a way that makes it as easy as possible for people to access them isn't just fourth year primary healthcare lingo, you know, accessibility, affordability, appropriateness, etc. It's real life. How do people come and get to the services that you're there to provide? And this isn't a paid advert, but this, I thought I should acknowledge where this wonderful picture comes from. Slingsby Maps, if you're in the Wild Coast, part of the Eastern Cape, where are we? Eastern Cape. Then I highly recommend getting this map. You can find it online. That's actually one of the links to it. It's got all the 4x4 tracks and paths and back roads, and you can do lots of fun exploring in your spare time. The third thing on this map is that it maps out where our main clinics are. And that's another thing about getting orientated to a new community. When you come and you ask somebody, where are they from? And they tell you Zidindi, you know, on day one, you're just going to give them a blank stare. Where is that? I have no idea. But once you can picture where Zidindi is, and you know, how do people get here from Zidindi compared to Mkatazo, or near the bottom next to that number 79. You know, if you tell me you're from Zidindi or Mkatazo, I've got a completely different sense of what it took to get to me, of how likely you are to come back for my care, etc., etc. So knowing where your clinics are, visually picturing them for yourself and getting a sense of what is involved in the transport to and from those places, or how do people live in those different communities, is really important as well in terms of your own local orientation. Quick word on NGO partnerships. I'm going to try and stop soon so there's time for questions. I'm not even sure what time this was advertised to, Madeleine. Just start waving at me when you think I've said enough. NGO partnerships, there are a couple of kind of provincial level ones. I've put the three main ones I'm aware of there. Equity Innovations is doing a lot of work in the TB sphere. Right to Care is helping with coordinating a bunch of things, including in COVID. TB HIV care, you often find them on the ground in more the clinic and CHC settings. Unfortunately, I'm a little bit of an NGO skeptic when it comes to big NGOs. I'm a much bigger believer in small NGOs. So the 5 on the right are our NGOs. They're Zithulele-based NGOs. Everything from Jabulani, which we started ourselves to support the hospital and do development work in the community. I'm using that phrase so that you can copy it. To the school down there, there's an independent school at Zithulele. This isn't a recruitment drive, but who knows, you know, rural health leads you into funny things. So be prepared. But the key thing is local partnerships. Who is around? Who's there to offer help? The reality is that sometimes, either because of mandate or because of capacity or because of budget, government can't do everything. Local NGOs are often a lot more responsive than big ones, but they take a lot of time and effort and nurturing. Over time, however, the value they add is tremendous. And again, it's a subtle balance sometimes. The point of NGOs is not to bail government out or do our work for us. That's all too often the response of government staff to people coming from outside, but to really work alongside us and make more possible, I think, or to make more better, what we do better can help. So yeah, I would love to share with you some more of those stories, but we don't have time for that now. If you are interested in starting your own NGO or working out how something like that can work, I know there are a number of other hospitals which have NGOs as well, supporting them in different ways. And I highly recommend it, especially if you see yourself being in a rural place for a longer period of time. This can really add value to what you do, add value to your patients' lives, and also reduce your frustration sometimes. Boring admin, we're not going to talk about this in long detail, but I thought I'd put some of it out there just to nudge your thinking, or to get you to ask yourself, do you know what those things are? Do they exist in my hospital? Leave, hopefully that exists in your hospital. There's lots of different types of leave. This isn't even all of them, but it's the main types. So annual leave, you get 22 days if you just showed up. If you stick around for 10 years, you get 30 days. It's very cool. 30 days is much better than 22. So stick around. It's also important that at the end of your service, you should transfer to places if you're going elsewhere in government, because otherwise you start again and then you lose your 30 days. Okay, that was for free. Sick leave, it's really meant for people who are sick, but as you know, that's not always the case in the world. You get 12 days if you're on a 1-year contract. You get 36 days spread over 3 years if you're a permanent employee. And that cycle is actually coordinated for everyone. So this year is the 3rd year in a 3-year cycle. Paternity leave is a relatively new invention. You get 10 days paternity leave now. Adoption leave, the rules have just changed on there as well. And the leave isn't really a reason to adopt a child, but if you do adopt a child and they're less than 2 years old, you get 45 days. How cool is that? Or 10 days if they're older than 2 years. And family responsibility leave, that's really falls into 2 categories. If your child, spouse or life partner is ill, you can take leave to attend to their needs. And then if one of a kind of whole host of possible relatives passes away, you can get up to 5 days of family responsibility leave. There are restrictions on that, and the overall number of family responsibility leave days in the year is set at 5, limited to 5. But as Madeleine said, you can find the official leave policy for that. And PMDS, the less said about PMDS, the better. Okay, wait, I'm in public here. Okay, I'll try to be polite. It's the Performance Management and Development System. It's a terrible way to assess clinical people, but it's paperwork that has to be done. Find out from your nearest friendly HR or clinical manager, not me. Right. Timesheets, they also have to be done because the auditor comes along and asks your poor HR or your clinical manager, did this person actually come to work? Doctors are the worst at doing timesheets, so just cooperate and do them. That's a friendly plea. Now, you should be writing down that you came to work. You'll be surprised what happens. Procurement, wow, that's a whole nother story in itself, but there's a whole lot of paperwork. So the main reason for putting it here is to have sympathy for your procurement team. Maybe you have a chief physio or somebody who does procurement for you, appreciate them. When things arrive through the long process, celebrate it. There are a bunch of forms that you need to do, and basically it's a request form, which is called a log 1. You have to do a specification form, so you can't just say you want an anesthetic machine. You have to say you want an anesthetic machine that was, invented after 2000, that dispenses gas and has a ventilator or whatever it is, okay? You can't just say you want crutches. You must say you want aluminium crutches with a ferrule on the bottom. Then you need a memo motivating for it, and then that needs to all be approved. And then that goes off and gets another whole tree's worth of paper chopped down with it, including tax clearance certificates, etc., from the companies that you got quotes from. I'm rushing along now. Referral pathways, they're worthwhile finding out about. Quick advert, the Zithulele Doctor's Handbook has a whole section on referral pathways to Mthatha. Sorry if you're in the Western region. It will tell you how to refer into the various clinics at Nelson Mandela, and has numbers of heads of department and the outpatient landline, etc. That's worth getting. The electronic version is freely available. Madeleine, maybe you can share it with people who send you their email addresses. If you want a printed copy, and you can work out how to get one from me to you. I think we managed to get them for 90 Rand this year, so that's their cost price. We're not making a profit on them, but you find it's a practical help to what you're doing, but also, like I said, in referral, it will give you some sense of who to send where and who to phone for what. But make friends with the people at your referral hospital. I've often thought that we do badly by just saying, send this one to that. If we could start creating referral relationships, when you phone the doctor on the other side, they know who you are and you know who they are. Wow, wouldn't that be a great world to live in? Okay, so I'm an idealist at heart. Ambulances, they're in the garage. Some of them are out on the road. Madeleine's laughing at me. Book them well in advance. Be as specific as possible as to what you need, including oxygen. Assume nothing. Get to know the local tricks of your own brigade. Wow, I am politically incorrect when it comes to ambulances, but these are the challenges you face. Prepared to spend long hours on the phone. Realize that you're not alone in facing that challenge. Okay, I've got some work to do there. EAP, Employee Assistance Program. If you've got a problem that's not being solved by someone near you, then there's actually opportunity to ask for help. If you're finding yourself tempted to be addicted to pethidine or with an alcohol problem, ask for help. That's real life stuff, and we don't want to make light of it. And even if you're in a small place and you've got a colleague who's struggling with that kind of stuff, there's an employee assistance program that really does exist and that really is there to help people. And don't wait until people are drunk at work and not showing up, because then they're digging a hole for themselves, or you're digging a hole for yourself. So that's an important part about rural health, is actually looking after yourself. And there's more to come, I think, in this program from Madeleine about avoiding burnout, etc. Sport, lots of hospitals have sport. If they don't, find some people to kick a ball around with, or toss a netball into a hoop, or play ultimate frisbee. It's very resource friendly. The Zithulele team is the second-ranked provincial team in the country. None of us at the hospital are good enough to actually play on that team anymore, but it started as a hospital thing. And the last thing on my list there is women at work. That's for me to be a little bit provocative, because one of my kind of bugbears is that the public service is not actually designed to be friendly to women, especially women who have families and kids. And so my challenge is, if you're setting out on that journey, whether you are a man or a woman or identify as anything else, understanding the challenges that women face in terms of full-time careers or part-time careers, there's more flexibility in the public sector than people realize. Not necessarily if you're a ComServe, but building an appreciation and a sensitivity for the competing demands on women, and the fact that many of them end up feeling that they are not 100% at work or 100% at home. Those are important realities, and I think that we really should be dealing with that more as rural institutions, because when you are able to provide the kind of place that people can live and have a family and work at, you start to build long-term stability. So I'm just throwing that out there. We're nearly done. This slide is just a shout out to the reality that your life as a healthcare professional is often about balancing responsibilities, and that those responsibilities are to a diverse range of people who you maybe didn't even think about having a responsibility to. You've got responsibilities to your patients. You've got colleagues who you're responsible to, and perhaps in a rural hospital more so than elsewhere, because they're also the people you walk home from work with and then socialize over dinner, or go to the beach with if you're lucky enough to live near the coast, or go hiking with in the mountains. Responsibility to students. Many of our institutions have students. In fact, some of us have interns for the first time. We want to be providing the kind of service and hospital and conversations that we wished we'd got as students. Okay, so remember that rural hospitals, if you give students, undergraduates, a positive experience of a rural hospital, they are statistically more likely to work in a rural hospital. So the best thing we can do for improving rural health is give students positive experiences. We've got responsibilities to our professions, and I would really encourage you not to let go of that. Not that you're about to, that's maybe the thing we hold to the most, and that's good and right. Prioritizing patient care is our number one core value, because at the end of the day, if we're not doing that, what are we doing here? So hold on to that. We have responsibilities to our employer as well, and sometimes those can feel almost conflictual with some of those other responsibilities. But nonetheless, it's important to try and be a good employee, whatever that means, and to work out what it is that's at issue when you are feeling conflicted. And then, not because it's the least important, but because it can easily be shoved out of the way by those other things. Learning to have a family and social life that is balanced as well. Phew, good luck. Right. Okay. Last slide. I think this is the last slide. I hope so. The two questions. It's now 6, but I still call it the 2 questions. Like I said, I love numbers. Okay. These are the 2 most important questions in rural health. Where do you come from? Not you. Where does your patient come from? And how did you get here today? If that's the only thing you remember from this talk, it's well worth it, because it changes everything about how you manage your patients. And forgive me if you've heard my story before, but I've been taught this so often, but I clearly remember the first day it dawned on me. Me, a white middle-class South African who grew up in a city, working in Ngwelezan Hospital, a regional hospital in KZN, sitting in a surgical firm that saw patients and outpatients on a Thursday and operated on a Monday, whereas the other firm saw their outpatients on a Wednesday and operated on a Thursday. So Thursday morning, first man in the door is a old man who was meant to be here the day before, because he was meant to be having his operation today. And I'm like, but you were meant to be here yesterday. Why are you here now? And he was really apologetic, and he explained to me that he was very sorry, but where he lives, it's been raining a lot, and he wasn't able to cross the river to walk to catch the taxi to get to his district hospital and wait there until the bus came at midnight to bring him 5 hours to come and arrive at Ngwelezan and wait on the bench until the clerks opened and he could get his file and come and wait in a queue for me and then see me. And I get goosebumps even today telling that story, and I've told that story so many times, because it blew me away. And that's the reality of our patients, that people make the most extraordinary effort to get to us. On top of it, he hadn't had anything to eat, which turned out to be a good thing, because I could go to the surgeons and say, your patient's here and he's starved. Can you put him on the list? So he got his surgery. But then so many times where that lesson has helped me provide better care to my patient, realizing that they got here by walking and having to rest every 30 meters and sit on a stone, that they got here by spending 800 Rand or 1,000 Rand to hire a private car to come. You can't ask that kind of patient to go back and come again in 2 days' time to check how they're doing. So please, more than anything else, those 2 questions, whether you work rural or urban, are the most important questions, I think. But these other 4 are also important. Is this care good enough for me? I think that's an important question for us in rural health. It used to be that rural health was kind of like the poor cousin, and it doesn't have to be. The reality is that our context is challenging and our resources are fewer, but we need to be doing the best we can. And we need to be trying to get better. I say endlessly to our staff, we're never going to be perfect. We want to be trying to get a little bit better all the time. That third or fifth question, is this battle worth fighting now? That's a super important question, especially if you're in ComServe and especially if you're only going to be there for a year. Don't pick a 5-year project to try and turn around like the HIV service, and that and you take it on in all its glory and try and get everything fixed, because in January next year it will just go back to how it was. Pick something that you can achieve in a year if you're only going to be there for a year. If you're going to be there for 5 years, pick the 5-year project, of course. Pick something you can achieve. You can't fight every battle. We can't. We've got to find the sweet spot of being dissatisfied enough with what is wrong, but also satisfied enough that we can still be here tomorrow to keep making a difference. And the last one is just, it feels like a throwaway, but is that the name in your ID? Super useful in maternity. You won't believe how many letters I've written for women who've used their neighbors or their grannies or some other name. And then when they apply for their child support grant, it becomes a real mission and they have to reapply for IDs and things. So it's always a good question to ask. If you ever get an email from me, you'll see my signature line is, if you don't have a dream, how will you ever have a dream come true? The Eastern Cape is a fantastic place to work. It's got plenty of challenge, but it's got plenty of opportunity. You're constantly learning new things and there are always new surprises, but I hope that wherever you are, that it will be a really fulfilling year. There's a bunch of us around who you can ask questions of, clinical or otherwise. And yeah, hopefully just knowing that there are other people facing the same challenges as you will help you feel less alone. Madeleine, that's all I have to say. I hope I wasn't too long. I see it is past 7. My apologies. If there are questions, I'm very happy to take any of them.
Oh, thank you very, very much, Ben. Yes, we do have an hour and a half, but I know some people might be leaving at 7, and that's not an issue. Everything is recorded and will be made available. We've got one, we're just, in terms of just how many we're about 35 people who came and went. That's amazing for a first night to get going. And I always love to hear Ben speak. I mean, all the slides about how the DOH works and all of that is all very useful, but I think what's the most useful is those very personal touches and stories of somebody who's worked in rural health for a really long time and has shown us what it looks like to thrive in rural health, even under sometimes very difficult circumstances. So we really appreciate it. There was one question on the chat, 2 questions by the same person who's actually sort of related, which has to do with budget allocation. So the first question was about budget allocation to the different hospitals in the area. How does that work? Do all hospitals get a standard budget? Or how do they determine how much each hospital gets paid? And then her second question, which I think was probably related to why she asked that, is why do you have some hospitals that seem to have no staff at all? And then you have hospitals like Zithulele that seems to have the whole complement plus extra. At times, I know it doesn't always, it does go up and down like that. But what is this dynamics between why some hospitals, even in the same district, sometimes seems better resourced than others? And I think you already gave us a nice background in terms of how the money gets shared, that pot, who gets what of the pot. So yeah, if you could tell us a bit more about that.
Yeah, I mean, I think in some ways it's a local reflection of the rich getting richer and the poor getting poorer, often for those reasons of capacity that I spoke about. So on one hand, it's because of tenacity. So, for example, our CEO post has been vacant since the end of July, and I have the dubious honor of being the acting CEO at the moment. But even today, I was writing to the SG and saying, SG, just so you remember, I'm not going to be the acting CEO forever. I need a CEO. And I'm going to keep asking until I get it. Not because I think a CEO is a special favor or I'm somebody special, because I think hospitals should have a CEO. And so I've got to keep asking. So all of our kind of posts have been from steadily asking, and then when someone leaves, getting them filled quickly again. It's a long process, but obviously our longevity, there's a couple of us who've been here for a while now, but also my longevity in the management position does help because as soon as something comes vacant, we're pushing to get it filled. We've got people now who want to come. That momentum is amazing. I mean, we got to the point where we actually had the opportunity to choose. It was a little bit freaky because in the past we were just like, "What, you want to come and work?" It's great, come. Who are you? Where did you come from? Those questions almost got asked as an afterthought. Whereas now we get to choose, which is another kind of problem. But it's about momentum, and momentum takes a long time to build. But once you have momentum, it actually is easier to maintain. And so what you see is the smaller hospitals often going through kind of that same circle of trying to hold on to 4 doctors. But because it's always a different 4 doctors, you end up not being able to build new momentum and add on to your service. And it is, I mean, it's a complex ethical question. Hey, I mean, is it really okay for me to be motivating for another, what? And I mean, mostly we're now posts are full, so I'm not motivating for another, I'm motivating to keep. But it's still a challenge, isn't it? Knowing that other hospitals don't have, and yet I often interpret my, I'm here to advocate for my community within the context. I have to be realistic, but we've got to advocate for our communities. I mean, I think that there was a question about, so it's not budget, but it is budget, because of course, once you're in the system on per cell, money's allocated against that post. There was another aspect.
Just in terms of how does budgets, so how do they decide how much money each hospital gets every year? Is that all to do with historically what's happened the year before? Or is there a standard, a district hospital of this size gets so much money?
Yeah. Do you want the politically correct answer or not? It's a mysterious process. I don't think anyone actually knows the answer to that question, Madeleine, in the whole province. I mean, I'm sure there maybe are people. I don't know. Okay, so theoretically, the way you should do budgeting is that you should say, okay, well, we've got this number of patients, and they use, people go to the toilet twice a day, and so we need X amount of toilet paper for a day's worth of patients in our hospital, and we multiply that by 365, and we take 10% kind of for our miscalculation. So we need X number of toilet rolls, and toilet rolls cost X amount, and therefore the amount of money in the budget for toilet rolls should be that. Okay. And I mean, that's how budgeting works from start to finish. I start with toilet rolls and you end with anesthetic machines. Okay. What happens, unfortunately, a lot of the time is that because people don't trust the process, the very original budgets, and there are all sorts of fancy names for the forms involved, which I don't know or remember. But we go like, toilet paper. We need 40,000 Rand for toilet paper. Okay, so I mean, how did we get to that number? Nobody knows. All right, so we put that number to district, and district go like, whoa, everyone's asking for 40,000 Rand for toilet paper. No, that's not going to work. Let's cut it down to 30,000 for everyone. Okay, so we do 30,000 for everyone, and then it goes to Bishu, and Bishu goes like, what? No ways, we don't have that money we don't have that much money for toilet paper. It's going to be 25,000. So you see, next year we know that that's going to happen. So next year we're going to ask for 50,000 for toilet paper. That's roughly how budgeting has been done, and that's a complete oversimplification and a real insult to the people who do actually spend genuine time on it. But that, honestly, it feels like that's how the process happens a lot of the time. It's different when it comes to compensation of employees, because we're on the system. So Purcell sees us, and then basically says, oh, well, this is how much those employees are going to cost. But then we still fiddle the numbers a little bit. And that's before you get to accruals. So you run a 2 million Rand budget, lab budget, and then you don't pay it. Basically, we use NHLS as a bank. So we don't pay it, and then we carry it over to next year, and then they allocate us 2 million Rand for the lab, and then we pay last year's 2 million Rand. And we're like, oh, we don't have money for the lab, and then we manage to kind of beg, borrow, and steal some money into this year's budget. So it's a bit of a complex mess, to tell you the honest truth. But the more people that you've got working on it, and the more people you've got advocating for what it is, the more money you're going to get at the end of the day. And the system is almost designed like that. It shouldn't be, but especially in a province like the Eastern Cape, where we've got reduced capacity, it almost inevitably ends up like that.
Thank you very much. I think you've given a good picture of the complexity there. And I think we have the same problem nationally. So that's actually, there was already this talk in the Treasury about going back to what you was describing as zero budgeting, this thing of counting all the toilet paper. But can you imagine in a hospital the amount of line items there are that you would have to work out from scratch? So the simple reality is there's nobody that actually has the time or the capacity to sit down and work through that whole. So we tend to do this guesswork, sometimes looking at, well, how much did we spend last year? And one of the issues of historical budgeting, so you look at, as you've said, well, we got this much last year, it wasn't quite enough, so I'm going to ask for more this year, is that programs change. So, for example, when we ran out the IPT program, we never had enough money in the budget for the MAN2 tests when that first happened, because we suddenly needed a lot more. But historically, we were still budgeting and ordering on old numbers. So those are one of the challenges. So I just want to mention stakeholders here that's useful to know of is an organization called the Rural Health Advocacy Project. And Jenny has also, Nash has made a comment on the chat group there about this importance of being able to think of the province a little bit as a whole, and there the RHAP can help us. So one of the questions we've really asked is, how do we actually calculate how much staff a hospital needs? Because even that's a little bit, I think people are almost scared to do that calculation because they're going to come up and go, oh, but we can't afford that. But actually that'll be useful, is to start actually using some of those. There is various formulas out there to be able to say, this is the amount of staff we need. This is how many we actually have in the organogram, and how we're going to make do until we can eventually build up an organogram that we can actually afford. And be realistic about how much staff we have and what we can actually do with that staff and what can be expected of us with that staff. So, for example, Katlebe a few years ago really ran into trouble in terms of the amount of doctors that they had. And the Rural Health Advocacy Project came in and just helped to speak to the right stakeholders, looking at also who was around, who could help from other facilities for a short period of time, and ended up helping to get doctors appointed. So it's useful to make use of some of these advocacy organizations who don't come in, this is not, walking around with posters outside the hospital, but these are people that help smooth sometimes some of that conversations that can be difficult conversations, and help to build relationships. So I think that's one of the reality. We want to, there's another question here. So this is quite an ethical question, and I'm going to ask that we're going to leave that for one of our future discussions, because I think that's almost a whole presentation on its own side, and it has to do with you noticing unethical things happening inside your hospital. So there's an amazing project called the Voice Project. We will put some of that materials on the program as well. RHAP, we're also done through RHAP. That looks at all the dynamics around finding that balance between confidentiality and supporting colleagues and fixing things on the ground, and not keeping quiet when you, and when do you intervene, and how do you do that, and how do you do that appropriately? So the Life Esidimeni project, my pronunciation, a few years ago was a good example of that, where they were saying why healthcare workers hadn't spoken out when they were supposed to. And then the other extreme is when things end up in the media without proper procedure having been followed, and everybody just gets embarrassed and angry and nothing changes anyway. So that, what our legal obligations are, what we covered for, there's a whole whistleblowing law, for example, at which point you're allowed to whistleblow, and what happens before you do that to also protect yourself. And that is a whole topic in its own right. If you want to look up on yourself, Google the Voice Project from RHAP. They have an excellent website with excellent resources and all the legal documents around that. So I don't think we're going to cover that at this point.
Yeah, I mean, Madeleine, if I can just come in, I think that and actually relating to another question as well that Vriel has put there about building relationships with the community. I think the thing I'd like to emphasize the most, and whether it's in the hospital or the community, is the importance of relationships. There's a lot wrong in the world, and sometimes we need to be kind of shouting about it, but oftentimes the change comes most by working with and alongside people who you might initially see as part of the problem. My younger self probably wouldn't have had too much time for me saying this right now. But if there's one thing that rural health has taught me, it is the value of relationships and trying to really see and understand, and then work towards change. And that doesn't mean you have to compromise standards. You can be clear about kind of what's wrong. And I think, sometimes the temptation is there that it feels so wrong, or it is so wrong, that you almost kind of want to blow it all up, kind of go out in a blaze of glory. But number one, I don't think that actually brings much change, but I do think that you know, over the long term, you bring more change by working within the system. But I mean, that's really difficult, because obviously there are some things that are completely unacceptable, and obviously there's some people who unfortunately have allowed their practice to degenerate to the point where it is, you know, unethical. But often that's also a symptom of the system. So I think that one has to calibrate your response carefully there. And I mean, often it is about seeking wisdom from other people who've been in the system or faced similar circumstances. But then to just come to Viola more specifically, I mean, I think building trust and respect from the community takes time, and it really requires being present for a long time. I mean, for us, funnily enough, one of the things that really helped was we'd often thought we'd, you know, maybe one day build a house in the community, and then about 6 months after we got here, we learned that they were planning to knock down the house we were staying in, and build 2-bedroom flats. Now we plan to have a larger family than that, and we wanted to be long-term and homeschool our kids and stuff like that. So our program of building was rather accelerated. But building a house in the community, man, suddenly people were like, wow, you're serious about being here long-term. And I mean, it's not that everyone is going to go and build a house, but it's those kind of conversations and signals. But just realizing that even if you completely believe yourself, people are going to take time to see that you're serious, and they're going to take time to check you out in all sorts of ways. But being there, connecting with key people in the community, and just being patient, there's very little substitute for time.
Thank you very, very much. I think I want to bring things to a close, because we're getting to the getting from a time point of view, and I just wanted to, I'm just going to share my details. So for those of you who have not yet seen this, there we go. So tonight is getting us started. I think, Ben, this has been an excellent way to show us what orientation means. And as you can see, we're not going through every policy. We're not dealing with every point in detail. You can read up a lot of that stuff on your own time, but it's more to give direction. This is something you might find useful. This is something that you can look at. I will also just want to welcome, and I hope they're still all on the group. We actually have excellent mentors who actually were listening in today. Dr. Jenny Nash, our DCST from the Amatola. You'll see some of the webinars, recorded webinars, is from Jenny. We've got Dr. Mandondo. She's our superstar obstetrician, proper DCST rural obstetrician from the Amatola district as well. Extraordinary also in terms of providing us with materials, and we'll definitely also cover one of the sessions in terms of your top tips for maternity care. And so what is going to happen is, if you want to sign up to the 6 weeks program, and all that means is that you'll be getting weekly emails from me with the program. This is for those of you not yet, came a little bit later, this is what for example, this week's program will look like. And I'm already going to add some extra resources to that. I'm going to add the link for Ben's book, as well as the Zithulele handbook, for example, of resources that you can download and use. And every week we'll send you a whole bunch of stuff, and you can pick and choose what's useful for you. So if you already have a lot of experience in one field, you might not need to go through this. If you're confident with TB and HIV, you might not need to look at that. But if you've never seen a patient with drug-resistant TB, you might want to do a little online course on that. So the idea is that you can capacitate yourself depending on the areas where you might not feel so confident, or maybe depending on which rotation, which department you're working on within your hospital. So please do send me an email if you've not yet. And I think I've got everybody's email addresses on there. If you don't hear from me within the next day, then just email me. But I have taken everybody's email addresses, and we'll send you all welcome packs, as well as the program with the materials and the links for this week. The other exciting thing that's happening this week is a Zoom session this week on Wednesday evening at 5 o'clock. This is one of the WUSU Family Medicine series tutorials that happens every week anyway. And we are all very welcome to join. It's sort of for any district hospital level doctor, not just newbies. And this week, Dr. Norrie Gibson, who is HOD from Frere Hospital, is going to talk a little bit about Colles fractures, etc., and reduction of fractures, as well as, if there's time, doing a hematoma block. I think Joyce Gibson, the anaesthetist, is going to join in. So we'll send you all of those links as well for those of you that would like to join. Just a very warm welcome to all of you for starting us up. You can see this is a program and process, but we are very excited to actually be running and rolling. And I just want to see if there's anything lost on the chat. Great. So yes, no other questions at this point. So I'm going to close the meeting at this stage. Anybody wants to stay afterwards and ask a question, you're very welcome to. I'm going to be on here for at least 5 or 10 minutes just doing some admin. And I wish you all a lovely evening and a good week ahead. Good night, everybody.